We will start with, bar none, the most common pediatric upper airway pathology that we encounter, and that is a laryngotracheobronchitis, aka croup. The classic presentation of croup: kid doesn't feel well, maybe has a low-grade fever, maybe is snotty, irritable, goes to sleep, wakes up in the middle of the night with this seal bark-like cough, and if they're talking yet, they have a voice that sounds like Tara Reid.
I mean, we already gone to outer space. I already had a baby.
Or that Miley Cyrus meme.
The journey is usually the part that you remember anyways.
Croup is a viral infection of the upper airway that results in inflammation that narrows the tracheal diameter, and that causes turbulent airflow. You can really get some scary tracheal stenosis. You can see it on the x-ray here, and for those of you who are thinking of taking the FPC or the CFRN, the tracheal stenosis from croup is called steeple sign on the x-ray. Treatment is to nebulize racemic epinephrine or epinephrine. Oh my God, what about the increase in heart rate in a kid that's already going to be tachycardic because they're sick? Just give it. It's totally safe. Yes, it's catecholamine, a sympathomimetic. That's why we give it, for the alpha-1 vasoconstrictive effects. But these stories of malignant arrhythmias and dangerous, well, they're good for telling scary stories to Girl Scouts around a campfire, but real world, unless the kid has some weird congenital heart defect, epi and racemic epi are totally safe to use in croup. In fact, as the epi vasoconstricts the swollen airway and reduces inflammation, you might actually see the heart rate start to normalize as the kid starts to feel better. It's a misconception that racemic epinephrine is preferred over epinephrine because it causes less of an increase in heart rate and less cardiac side effects. You can find this in several sources, but in reality, racemic epinephrine and epinephrine will cause the same degree of cardiovascular effects, which again is not much. Do not withhold it. When you are giving racemic epinephrine, you're giving two chemical flavors of epi, epinephrine L and epinephrine D. In regular old epinephrine 1 to 1000, they're just getting epinephrine L. However, both are very effective. One thing you don't want to do is nebulize albuterol. First, it doesn't work. Croup is an upper airway pathology. Albuterol works on bronchial smooth muscle, which is located in the lower airways. However, albuterol can actually worsen tracheal swelling in croup patients through vasodilation of the upper airway vasculature. These kids also need steroids to reduce the inflammation. Now, it is really shitty practice to start an IV in these kids, to give them Solumedrol, or stab them with a needle to give them an IM dose. The most common practice is to give the IV preparation of dexamethasone orally because it's an easy volume for the kid to handle, and while I'm sure it tastes terrible, it's one and done, and it works wonders. You will hear people say that maybe you shouldn't give steroids to the croup kid because that is associated with longer hospital stays. But this is where PubMed and the letter to the editors clash with common sense. Yes, no shit. If the kid is sick enough to require steroids, they typically are going to be in the hospital longer than a kid that does not require steroids. Do not withhold steroids for the dyspneic and sick croup kid. Here's the real deal, people. Croup looks scary. However, you treat it appropriately, and 99 out of 100 times, it's a nothing burger. Less than 1% of kids with croup require intubation, even if they have severe tracheal stenosis. And of those kids that are intubated, barring a congenital or some weird chronic illness, virtually all of the kids do absolutely fine. Next thing to talk about is bacterial tracheitis. This is a bacterial superinfection of the upper airway that occurs in kids with croup. Croup's viral, kids sick, immune system's taking a hit. Bacteria take the opportunity to kick the kid while he, she, or they, them is down, and they colonize that sick upper airway. This creates a hard crust of mucus and grossness. This is a leading cause of respiratory failure in the otherwise healthy child. They used to say, oh my God, these kids all die, and usually you find out they had bacterial tracheitis on the autopsy. This is another urban legend. It's not that bad. Kids with this get better all of the time. However, make no mistake about it, these kids can be very sick. As always, avoid hypoxia like the plague, and keep it in the back of your head that these kids may need airway management and artificial ventilation. Then we have epiglottitis, usually due to Haemophilus influenza B. which is a bacterial infection, which I know influenza is a virus. It's confusing to me too, but I didn't come up with the name. Don't blame me. It's pretty rare these days because the vaccinations are good. However, there are people that don't get their kids vaccinated. It used to be liberal hippies that didn't get their kids vaccinated, but now it's gun-toting, Bible-banging conservatives who think that Jewish lasers started the California wildfires, who don't get their kids vaccinated, and now it's the liberals who are all about getting 750,000 doses of whatever Pfizer says to get. What a weird world we live in. Anyway, unvaccinated kids are at risk for epiglottitis. Super uncommon to see in anyone who got their vaccines. Example, EMS providers who work in areas with large Amish populations will tell you that they do see epiglottitis from time to time. When you do see it, get ready because it's going to be an ass pucker. Classic epiglottitis story is like croup, kids sick, upper respiratory tract infection, snotty, hissy, cryy, febrile. They wake up in the middle of the night with a high fever, extremely dyspneic, inspiratory stridor, and what they describe as a brassy cough, whatever the hell that means. You critical care test takers, you see thumbprint sign on x-ray. They love to ask you to differentiate epiglottitis from croup on these exams. The classic medic school scenario testing answer is don't fuck with the kid. Don't piss him off. Just get him to the hospital without delay. In the event that you do need to intervene and take over airway and breathing, BVM, they're going to require some high pressures to ventilate. And holy shit, if you need to intubate them, buckle up, because if they have a kid with epiglottitis, they need to intubate in the hospital. They do it in the OR with a whole team of anesthesiologists and surgeons available. But if you must do it, get ready for seeing a whole lot of nothing. Best intubator on the team does it. You likely won't see jack squat, so you can do chest compressions to generate bubbles in the airway. Aim for the bubbles and pray. The last thing I will talk about is tracheomalacia. This is where the upper airway has not developed structure. It's floppy and it collapses on itself when the kid is sick, dyspneic, crying, shouting, screaming. There's not a whole lot you need to know about it as an EMS provider other than just simple awareness. More often than not, kids with this will outgrow it. If it's really bad, simply manage the ABCs in the pre-hospital environment. It's a pediatric ENT surgical problem that you're not going to do a thing to fix.